black tarry stool or bright red vomit. When you see this, that color tells you exactly where your patient is bleeding from, and more importantly, just how fast the clock is ticking. Welcome back, nursing students. In today's explainer, we're going to help you completely master one of the absolute most tested med-surg topics you'll ever face on the NCLEX, gastrointestinal bleeding. We're breaking this all down so the facts actually stick, your prioritization becomes totally flawless, and you can walk right into that exam room with absolute confidence. Let's dive in. So whether it's that black tarry stool or bright red vomit, listen, in the real world and on your exam, these are not just gross details to memorize. They are critical life-saving clues. The color of the blood tells you exactly where that bleed is happening, and like I said, it tells you how fast the clock is ticking for your patient. GI bleeding is, simply put, blood loss anywhere in the digestive tract. And whether it's a slow, hidden trickle that's been going on for days or a massive, sudden hemorrhage, significant bleeding can rapidly push your patient straight into hypovolemic shock. And that brings us to the most dangerous aspect of this whole condition, the ticking clock. When a source in the GI tract starts bleeding, circulating blood volume obviously drops, and the patient's body desperately tries to compensate. Here is what is absolutely crucial. You have to recognize the early warnings. Tachycardia and orthostatic changes will always appear before hypotension. Think about it. The heart is beating faster to pump whatever volume is left before the pressure actually bottoms out. You cannot wait for a low blood pressure to act. If that blood loss continues, you're going to hit the late signs: hypotension, pallor, and that cool, clammy skin. Left untreated, multi-organ hypoperfusion sets in. You'll see dizziness, a sharp drop in urine output, an altered level of consciousness, and eventually, death. Okay, so where is all this blood actually coming from? Anatomically, we divide GI bleeds into two main camps, upper and lower, and they're separated by a landmark called the ligament of Treitz. For an upper GI bleed, which involves the esophagus, the stomach, or the duodenum, peptic ulcers are your #1 cause. We also see esophageal varices, which are very often linked to cirrhosis and liver disease, and Mallory-Weiss tears. Now, moving further down the tract, a lower GI bleed originates from the small bowel, the colon, or the rectum. The common culprits down here: diverticulosis, hemorrhoids, and colorectal cancer. Now, let's connect those anatomical sources to the visual clues your patient will actually present with. This is going to be your memory hook, so lock this in. Hematemesis, which is vomiting bright red blood or that dark coffee ground-looking material, screams upper GI bleed. Melena, which is black tarry stool, also means an upper GI bleed. Why? Well, the blood has actually had time to travel through the digestive tract and get digested along the way, which turns it black and sticky. On the flip side, hematochezia is the passage of bright red blood per rectum. This tells you the bleeding is lower down in the GI tract because it hasn't had time to be digested. So, simple rule: fresh blood equals a lower source, digested blood equals an upper source. So, the big question: what do you, the nurse, actually do when this happens? We treat it just like any major hemorrhage. You strictly follow the ABCs. Step 1, airway and breathing. Slap on some high-flow oxygen and protect that airway, especially if they have hematemesis, because the aspiration risk is absolutely massive. Step 2, and honestly this is the big one, circulation. You need 2 large-bore IVs for fast volume resuscitation with isotonic fluids and blood products. Remember that, it's a huge NCLEX favorite. Step 3, monitor relentlessly for shock. Keep an eye on those continuous vital signs and urine output. Step 4, make the patient NPO and prep them for an endoscopy or colonoscopy to definitively locate and stop the bleeding. Depending on the source, you might be hanging an IV proton pump inhibitor like pantoprazole for an upper bleed or octreotide for varices. And finally, step 5, correct any underlying coagulopathy. Now, while you're doing all of this, you're obviously sending off labs, but you have to know what not to be fooled by. Take hemoglobin and hematocrit. Yes, they are eventually going to drop, but early on, they might be completely normal. It literally takes time for the fluid to equilibrate in the body. So do not be falsely reassured by a normal initial H&H if your patient is sitting there tachycardic and vomiting blood. We'll talk about BUN in just a second. Lactate, that goes up if there's tissue hyperperfusion, so it marks the severity of the shock. And you'll check coagulation studies, your PT/INR, to see if they need clotting factors corrected. Oh, and you absolutely must send a type and cross-match immediately so the blood bank can get those products ready. All right, let's zoom in on a highly tested NCLEX trap, an elevated bun with a normal creatinine. Now, normally when you see that, you think kidneys, right? But in this specific context, an isolated high bun points straight to an upper GI bleed. Here is the physiology of why this actually matters. Blood is incredibly rich in protein. When a patient bleeds into their upper GI tract, that blood gets broken down and digested. It's honestly kind of like a very weird protein shake. As the body absorbs that digested blood protein, the breakdown product, urea, floods right into the bloodstream, and that causes the bun to spike. But because the kidneys themselves are perfectly fine, the creatinine stays completely normal. So, if you see this on a test, think upper GI bleed. All right, time to put all this knowledge to the test. Let's see how well you can spot the true priority here. A client with an upper GI bleed has a BP of 88/50, a heart rate of 122, and is restless. What is the nurse's priority action? A. Obtain a stool sample. B. Establish large bore IV access and begin fluid resuscitation. C. Offer oral fluids. D. Ambulate the client. Drop your answer in the comments. 3, 2, 1. Boom, the answer is B. Establish large bore IV access and begin fluid resuscitation. If you chose B, amazing job. You recognize the ticking clock, that low blood pressure of 88/50, the high heart rate of 122, and the restlessness, which, by the way, is a key sign of altered LOC and poor brain perfusion. Those are classic textbook signs of hypovolemic shock from blood loss. Following your ABCs, the absolute immediate priority is restoring that circulating volume. A stool sample? That's diagnostic, sure, but it isn't life-saving. Oral fluids are totally contraindicated because they need to be NPO for a likely endoscopy. And ambulating a patient in shock, yeah, that is just asking for a massive fall. Let's do one more. We'll go a bit faster this time to really test your symptom recognition. Ready? A client passes black tarry stools. The nurse interprets this finding as consistent with A. Upper GI bleeding. B. Lower GI bleeding from hemorrhoids. C. Normal stool. D. Biliary obstruction. Get those answers in. 3, 2, 1. And the correct answer is A. Upper GI bleeding. Remember our visual memory trick from earlier? Melena, that black, sticky, tarry stool, results from blood that has been fully digested as it travels all the way down from the upper GI tract. If it were a lower GI bleed, like from hemorrhoids, it just wouldn't have time to digest. It would present as bright red blood, which we call hematochezia. Master GI bleed. 2 large bore IVs. Remember, the clock is ticking on hypovolemic shock. Will you catch those early signs before the pressure drops? If this made a click, subscribe. One killer med-surg topic every day until you pass the NCLEX.